think I let it off last time. Yeah, when we talk about the phantoms too, you need to talk about surgical man. Yeah, what are the studies show?
Absolutely.
That's it now.
That's why I said there'll be some over there. Sure.
You good lady.
Good morning and good afternoon, everyone. Thank you all so much for joining us today. This is the blueprint for establishing a holistic team approach for an upper limb amputees care in your community. We are honored to have both Doctors Gaston and Dr. Loeffler joining us today to host this summer surgeon webinar series that we have. And I appreciate everyone staying on mute during this session. And if you have any questions, please feel free to type them into the chat. We'd love to engage all of you after we go through this training webinar and be able to answer any questions that you may have with Doctors Gaston and Loeffler today. So I'm going to welcome and introduce Dr. Gaston and Dr. Loeffler. They're from the OrthoCarolina Reconstructive Center for Lost Limbs, which they both co-founded, along with the Starfish surgical procedure that they've pioneered together. And what we're focusing on today is really ensuring that there's a multidisciplinary approach and allowing for optimal amputee care in the community. So with all further ado, I'd love to turn it over to you, Dr. Gaston and Dr. Loeffler. Thank you all.
Thanks, Nicole.
Thank you, Nicole.
These have been great. These have been really good webinars, and it's been particularly nice, the questions that have come at the end. So like she said, certainly feel free to type anything in the chat, and we'll get to that towards the very end. So we're going to kind of walk you through how the two of us took this from an idea to an evolution in the clinic that we currently have. So back in 2016 in Charlotte, we had a high volume level 1 trauma center, and we were seeing increasing amputee patient volume. We recognized the evolving technological advancements that had been occurring and that new surgical procedures were coming out. This is right as TMR was just becoming a known entity. And the two of us had countless research study ideas that we wanted to do together. And I think one theme you'll take from this overall is having two physicians working together as part of a larger team has been magnificent for the two of us. It doubles our volume seeing these patients together. Two minds simply can outperform in terms of thinking through what's best for individual patients. And it's really become the day of the month that we both look the most forward to in spending time with these patients. We also called this, as Nicole alluded to, our Reconstructive Center for Lost Limbs. We recognized the need for there to be a special amputee clinic. And as I alluded to, the two of us doing it together allowed our experience to double every single time we do it. It allows us to have a clinic that's dedicated for these patients, and so they get a lot more attention. It's not like they're in my normal clinic just crammed in an established visit that's supposed to be 5 minutes when I'm in between carpal tunnels. This is they get a lot more individual time, and it really is a multidisciplinary clinic. And we have prosthetists, therapists that are dedicated to amputees, psychologists, nurse case managers, physicians. So everybody is one. And it's great for this patient population because decisions can be made and that information disseminated to the entire care team at once, as opposed to they come to us and we say, what did therapy say? I'm not sure. And then we have to send therapy in order, and then we have to send their prosthetist in order. Everybody's there and we all get on the same page right away. So it really streamlines their care. And one of the things we really preach about it is we tell patients right away, we don't treat just a missing arm, we treat the whole patient. And there's a lot of benefit to that. We do psychological screening for PTSD and depression at every single visit because a super high percentage of these patients is going to hit a point where there's a psychological stressor. PTSD and depression rates are between 50 and 60% in these patients that we've seen. And it's another great opportunity. Having multiple amputees in the room together is huge because so many of these patients have never seen another upper limb amputee. And last Thursday, we had 25 of them together. And that near peer education is impossible to replicate, and it's absolutely invaluable. I love the picture in the lower right. You see there the first patient on the left that ever had the Starfish procedure, talking to who ultimately became the second patient to ever have the Starfish procedure and telling him what it's like and how the hand works and uses. So that ability for them to trade advice with each other is absolutely tremendous. And we named it the Reconstructive Center for Lost Limbs because amputation in and of itself, an amputee can have a negative connotation. It's thinking of the limb as being lost, it's amputated, having a positive spin on it that we really are reconstructing what's left of the arm, not simply ablating it. So we felt that was a really important concept to emphasize when coming up with the name.
Today, Johnson is receiving her first.
This is a little piece on
at
CNN.
OrthoCarolina's
that I'll let you
Reconstructive
see
Center
about
for
the
Lost
clinic.
Limbs. Straight out. The people here have harrowing stories, but the ambiance is more friend's house than doctor's office. Doctors Bryan Loeffler and Gaston are two of a few surgeons worldwide pioneering a state-of-the-art surgical procedure.
He actually has implantable sensors in all the different muscles,
enabling the nervous system to communicate with artificial limbs.
Yeah, so that was after we did Starfish procedure, Sanjay Gupta came down and they did this piece on CNN, which really bolstered kind of the popularity of the clinic. And it's when it really became more of a nationwide draw as opposed to just a regional draw. In the center now, I think some of its success has really been this combination of focusing not just on the surgical care of the amputees as a surgeon, but on driving the entire continuity of care from a medical and surgical perspective, getting the inputs of prosthetists, having the occupational therapists. We've now even incorporated virtual reality as a way of helping to augment and treat their phantom limb pain. Pain management strategies that we take on as surgeons, providing peer support, psychological support, and then addressing return to work strategies and education and research.
Yeah, so I can go through kind of each one of those elements from the last slide and kind of dive a little deeper into to explain it. But the way we've set it up and what we've seen has worked well for us is, especially when starting the clinic, we really felt like both surgeons should be evaluating each one of these patients. And we set aside additional time. We put a lot less patients into a session than we normally would with our own separate schedules. And that just gave us the time to have dialogue with patients, and we really didn't know too much about what these patients are going through, what their needs are, what their goals are, and what kind of things we could do to help them without being really proactive and getting to know them and asking them questions about their day to day. And so we learned a ton from our patients and continue to. But when we evaluate them, we're seeing people who may or may not be candidates for surgery. They may be there more to talk about prosthetic options or medications or what can be done from a therapy standpoint to strengthen them, get the limb ready for them. So we really felt like it led to more fruitful and comprehensive discussions of just an entire gamut of reconstructive options when we're talking to these patients preoperatively. And then, of course, we take care of them through their entire post-op course, and we tell them, we're going to be friends for a while. When we meet them and we operate on them, we don't just do the surgery and then hand them off. We help guide them through the entire process. And again, as we've seen their recovery, we've just really become more experts on what that process is really like and what challenges they run into along the way. It's made us better with surgery, and it's made us better in terms of just being able to quarterback the care for the patients as well. We do involve ourselves in medication management, and I think an important part of that is what's done proactively on the front end. So a lot of times you'll see patients who are chronic amputees and, they've been managed with narcotics and they're on gabapentin, Lyrica, who knows, whatever else, ketamine, IV ketamine sessions, comas that they can go on, all kinds of different medications and things like that. And that's getting a little bit out of our, typical comfort zone as orthopedic surgeons, but we had to kind of embrace that because it's really a big part of it. And we really try to wean people down as much as possible off of those medications before the surgery. And it does show a lot of patient investment, if they'll take the time and effort to kind of wean down as much as they're able to. It also makes the perioperative pain management a lot more easy to do because all their receptors are not saturated with medication. So you have some room to control that bump in pain when they have the surgery. And quite frankly, it makes it easier to get them to wean off entirely in a lot of cases, as they go on months and months post-operatively as well. So that's been a big part of it. And we're now engaging our anesthesia team for the medical management to really bolster that in the perioperative period, looking at a multimodal pain management strategy. It's not just narcotics and the neuromodulators, but anti-inflammatories and Tylenol and et cetera. So then another big part of this is facilitating the occupational therapy. So, we have a certified hand therapist who's really become an expert as well in taking care of these patients. And so prehab, strengthening the muscles they have, post-op, getting the limb volume down, helping with the fitting, and then training them to use the prosthesis and maximizing their dexterity and control is a big part of that as well. And I think it really helps having that therapist in the clinic with us. Our therapist, Marcy, she's also become an expert on targeted brain rehabilitation, which we'll talk about at a future webinar. But, having a patient, learn strategies to deal with phantom limb pain and then allow them to train a virtual limb before their own limb is approved, by insurance, or before the limb is ready physically to wear a prosthesis, can give them a lot of psychological strength, and it can really make that transition into their prosthetic a lot easier as well. So we love to have the prosthetic team present as well. Patients can bring whatever prosthesis that they have been working with. If they haven't worked with a prosthetist yet, we'll introduce them to prosthetists to help smooth that introduction and relationship as well. And there's just so many challenges and barriers that the patients encounter, the prosthetists encounter, the therapists encounter, the surgeons encounter, the psychiatrists encounter, and work problems and things like that. And when you can get everybody on the same page in the same space and just have an open discussion about these things, it's so much more efficient for the patients, and it really allows you to come up with multimodal strategies to address all those things, and it helps a lot with finding the right solutions. We will also it facilitates conversations about, when is the arm ready to fit a shrinker, when is it going to be ready to fit, to start doing a molding and things like that. And they'll also help us, let us know, prosthetists will let us know, hey, we need you to document X, Y, and Z to help with the authorization for this. And it's not things that you would typically put, in an office note necessarily as a surgeon, but having those key words and just to let us know, like, hey, we're applying for, for a myoelectric, for example. We need you to state they've been using their body powered. They're having they're having difficulties with food preparation, hygiene, and other ADLs that you can specifically put in the note. That can help a lot with getting those authorizations. So that's another important way that they're a valuable part of the team. Well, we, as Dr. Gaston mentioned, we developed this Starfish procedure, and that's a reason that a lot of people have come to our clinic. So we take care of a ton of patients that have partial hand amputations, and they come in every shape and size and variety. and we've developed different algorithms based upon what they have left and what their goals are and what different prosthetic options there are. But we just still individualize the care, for each and every patient, and that's looking at things and discussing them and coming up with new innovations as well. But just a brief introduction of what it is essentially this is giving patients the ability to have individual digital control on myoelectric prosthetic. And the way we do that, if you look at that cross section of the hand, those are the metacarpals and those are the interosseous muscles where the lightning bolts are. We've actually transferred the third and fourth dorsal interosseous from in between the bones and the metacarpals where a surface electrode can't pick it up to putting it on the dorsal aspect of the metacarpals so that a surface electrode can detect the signal when those contract. And each one of those sensors is hooked up to an individual finger that can allow the individual digit on the myoelectric prosthetic to move. And the iDigits Quantum Hand is now an off-the-shelf option that ÖSSUR has put together after we developed our initial prototype years ago, and it's making it a lot easier to fit patients in. We have patients with 2 fingers, 3 fingers, and 4 fingers, and so those are all options due to this procedure in their prosthetic. So here's a guy who was active duty military, and you can see him with a 4-digit hand here. He can do a zipper, which is absolutely incredible. You saw him doing doorknob, and then you can see the dexterity he has to control each one of those fingers by itself. He can make some cool gestures. He can use it for a key, to dress himself, sort of pretty much anything you can think of. It's very intuitive because of the way we've done the muscle transfers and the way prosthetic design. And fortunately, it's really able to last all day. So he pretty much at times is worn it essentially all day, every day. So we also do stuff like TMR, which we kind of alluded to. And here's a guy who's a makeup artist, and he's at transhumeral level. We did TMR on him, got him fit, got him into a prosthetic, and he has incredible control, overhead control. You can just see here the way that he's able to do gestures and change his pinch and grip patterns. So this guy has unbelievable control, and that's not just doing the surgery, because we've done the surgery on many people who really weren't able to achieve that level of control and use of it, and it's because we've got all the elements in place. And we had a great therapist, we had a great prosthetist, we got a good fitting, we got the surgery, the muscles all work, and we got the insurance authorization, etc. And that's really what leads to it. But I always say it's the weakest link in the chain that's the limit for these patients. And so always remind our trainees and people that come to visit us, we can do the best surgery in the world. And yeah, that may help with things like preventing neuromas and improving residual limb pain, and it sets them up for success. But you're not always going to get that end result unless you got all the pieces of the puzzle in place. So we think that's pretty nice right there. So the whole concept really is treating the whole patient. That's what the clinic was founded on, was really this idea of treating the entire patient and not just being the surgeon that does their technical part and passes them along. So, one thing that this continues to evolve now, even 8 years after we established our clinic and hundreds of patients later. We've realized that things like TMR and RPNI are very good surgeries for treating and preventing neuromas, and they can also improve residual limb pain and make it more tolerable to wear prosthetics and improve their utilization of them. But one thing that's still really limited is if you ask them, a lot of these patients still have significant phantom limb pain, so pain that's going into the limb that's no longer there. And they, a lot of times, won't just come right out and say it. They're just kind of dealing with it. And that really is due to cortical reorganization, so an issue within the brain. And so your surgery on a limb does not fix a problem inside the brain in and of itself. So you want to talk about VR and TBR?
And we'll have an upcoming webinar a little more about this, but we've started incorporating what's TMR is what we use to prevent neuromas peripherally, and TBR, which is targeted brain rehabilitation, is what we're using to help treat it at the cortical level and treat the brain. So this is a program we've started using. It's a virtual reality system that's gaze-based, so they don't, since they're missing an arm, they can't always use controllers, and they're just looking at it, and they track it with their eyes. And this is one of the first patients we ever put it on. Just to set the stage, this guy gets a monthly ketamine-induced coma, takes Oxy 80 daily with a morphine for breakthrough and a fentanyl patch, and said that his pain routinely lives around an 8 to 9 and spikes to a 10 frequently, and that he hadn't been below like a 6, I think he said, in a couple of years. And this is the first time he ever put it on and used it for about 20 minutes.
So you've been having a fair amount of phantom pain up until now, correct? Or you tell me.
Correct. I mean, I could be sitting there and I'll shoot all the way up to a 9 for about 5 minutes, and it gets really bad.
How's it feel since you started putting the game on and feel your other hand?
It's gone down considerably.
What would you say? Kind of quantify that for me. What's your pain now on a scale of 1 to 10?
1 to 2, probably somewhere in between.
Cool.
Yeah, and so that's kind of what we've been seeing, and it's something we're following along for our established amputees, and we've also begun using this for prophylactic use. So now this was a 4-limb amputee who flew to us from Hawaii, and in basically the recovery room, we had her using the virtual reality system to help. And what it basically is doing is it's teaching the mind to see the hand that's still being there. What happens cortically is that section of the brain is lost and other areas grow in, and we're trying to keep that section present and or restored if it's been lost. And she preferred VR to opioids during her hospital stay, and the most dramatic improvement she had was a drop in one session from a 9 to a 2. And after 4 weeks, she was off all narcotic pain medicines, and she's actually back in Hawaii now. And we've touched on this piece of it is so critical, the psychological piece, because these patients, if you don't take ownership of this, they will just disappear. They will hit huge lows of depression. And so what we do is we screen them at every single visit. And if we see their numbers trending down, we have an on-site psychologist that'll go in the room and meet with them and then follow them as an outpatient. So she's handled numerous now amputees for us. And that's a tremendous benefit. And so don't underestimate the power of just multiple amputees being together, because they can see it in each other. The patients will be like, you know what, you seem down, I've been there, what's going on? And they'll open up to each other in ways that they won't open up to you necessarily. And another thing that we found really helpful is we try to have once or twice a year a big social gathering. This is one that we did at a local brewery. We had not just the patients, but their families, and it's great for spouses to talk to other spouses and their kids to talk to other kids. And then Dr. Loeffler and I would give a talk or so during it. But that just opportunity to socialize, because a lot of these people are agoraphobic. They just want to go home and be in their house and not ever get out. And these opportunities bring them there, and they feel so much more comfortable at somewhere where there's more amputees than they do otherwise. You want to talk about the occupational therapists and stuff?
Yeah, a lot of these
Return to work.
A lot of these, as you know, are work-related injuries, and so the work part of it is you just got to engage that too. I mean, you can't just ignore that part of it. And one of the first things we say to these patients are, what are your goals? You know, if a patient has no desire to ever return back to the site where the injury occurred because, it brings up bad memories, or because they were ready for a change anyway, or they just have a whole different mindset about their future, then there's no reason to try to bang your head against the wall and try to get them to do something. That's just never going to happen. But what we don't want to happen also is we don't want them to disappear. We don't want them to just withdraw and get some sort of settlement and then go on disability and just withdraw from society. So, we really try to bring them in and figure out, hey, if it's not going to be that, what's it going to be then? How are you going to use your time and your energy and your skills and all that? Because a lot of these are younger patients too. So we really like to bring the case managers in, and we're very proactive about encouraging them to come because they're a liaison between the patient and the adjuster, and it can help a lot with getting insurance approvals on things and finding out what the issues are with work and just being realistic about, what are they going to go back to, when are they going to go back, and all those kind of things. We really try to get them back to doing something as soon as possible. And if you look at the literature on this, the percentage of patients that go back and to work, it takes forever. And once they get past a certain window of time that they've been gone, it is really tough to get them back. But since we started this clinic, like the percentage of people that go back is way higher, and they go back a lot faster as well. And they might not be like as good as they're going to get when they get back to work. They may not even be in the best prosthetic they're going to be in, but they are way further along than they would be if they had kind of fragmented care. We also have done a ton with research and education. We think those are really important components of this. We got a very unique environment and situation that we have here, and we want to make the most of that experience. So that's sharing it with others through education and research. And we take functional outcome data, forms that patients completed every visit, which includes things like their pain management, whether they're wearing a prosthetic, when did they go back to work, or psychological screenings as well. And we put it all into an amputation registry, and that's allowed us to put out many different studies and publications and presentations every year, sharing the information that we've learned. We also just want to, get as many patients across the country and globe able to do these things that we have found such benefit in. And so we have a surgical education program where we will have surgeons and even prosthetists and therapists that will come to visit, and we'll spend the time to show them really, what's underneath the skin and what we're actually doing in our surgeries. And that can be really helpful for them to understand and take back to their communities as well. And even set up different centers of excellence really for multidisciplinary care of these patients. And so that's with visiting surgeons and visiting surgical teams, and then also just with residents and fellows that we educate. Some of them have gone on to set up their own clinics in different places across the country. And so this is what I was kind of mentioning, this visiting surgeon program. It's a very comprehensive program that we have that's over the course of 2 days, really, just discussing interesting cases, doing a cadaver lab, seeing how the clinic runs, the number of patients we see, interacting with the patients, and the therapists and prosthetists that we have here, and our psychologists, and then even coming to the OR with us. And we always do amputee cases the same day as our clinic. So it's a nice way to just put it all together. And we have something like that available pretty much every month. So it's been a great way to share the information. We look at the future of this. We've been increasing the amount of time in our clinic to accommodate increasing volume. We continue to have new ideas and new research and publications. We're working with a big level 1 trauma center here, so there's kind of a steady indigenous flow of patients, for upper and lower extremity care. We also do osseointegration coupled with one of the trauma surgeons at Atrium. So that's been another way that the clinic has grown as well. We have a 501c3, which is a nonprofit that raises money. It's called Arms for All, so that we can get prosthetics to patients who otherwise wouldn't be able to get them due to not having insurance or not having good enough insurance to cover it. And then we continue to work on pain management strategies, both surgically, medically, and then creating this scientifically driven VR therapy program, which has been a huge addition that we've done over the course of the last several months. We continue to innovate surgically, and we really want to incorporate evolving technologies to enhance the function of these patients and get them back to work. So we invite you to come on over and check it out. That was because we think it's okay. And there's our email. If anyone has any questions that come up, or pass it along to anyone who has an interest that's not on the webinar, we will see that and we'd be happy to respond.
Yeah, we can take any questions. I don't know if you want to open up the chat for us to see, Nicole. Let me see if I can find it. There's the chat. Yeah, let's scroll to the top.
How many prosthetists typically attend the clinic? We probably started with 2, and now we probably routinely, I would say, have 4 that are there. And it's just because if we see 25 patients in a morning, we just need that. We need that many people there because the visits, it's kind of everybody is coming through, and sometimes we're together, and sometimes they're just one-on-one time with the prosthetist. But yeah, we really will have like 4 at a time.
Yeah, and one of them says, do you typically have whole clinics or just single prosthetists attend? So the clinic's set up to where, like Bryan said, we'll have probably on average 20 to 25 patients in a half day. And if the patient has an existing prosthetist, then they typically bring their own prosthetist with them. If they're patients who are newer and don't have a prosthetist, then we'll introduce them to prosthetists at the clinic. And if we tried VR therapy with patients that have limbs affected with congenital differences, that's a good question. So we've done it in a different way. So most of the congenital amputees do not have phantom limb pain. In fact, I don't think I've ever met one that did. And they don't typically have any neuroma pain. So that's a cohort of patients who typically does not have any pain. Now we did what we thought was a very interesting study a couple of years ago, looking at can congenital amputees control multiple degrees of freedom's hands with a myoelectric prosthetic. In other words, would the brain send the signal to tell the hand to do things if the hand was never there to begin with? And we tested that in several children and found that yes, indeed, they can control that. And then we also tested it in adults that were congenital amputees and found that that's still maintained in adulthood. So we tested it with virtual reality and with direct signal testing and found that they can all do it. So they actually don't need virtual training because they can already do it, and they don't have phantom limb pain, and they don't have neuroma pain.
That's right. Yeah, I think it's because that part of the brain never really developed, So what happens when you have a amputation for some other reason is there's a part of the brain that's assigned to that part of the limb. And then when that limb is gone, that part of the brain is very confused and it becomes kind of a vacant space. And then that's when you get kind of the static noise and other parts of the brain kind of trying to jump in there. And the VR treatment, which is really building on things like mirror therapy and integrated motor imagery, helps to either preserve that part of the brain or to reteach it to control the limb, even though the limb's not there.
If I can talk, if that's okay. My daughter actually has a lower limb affected as well as some fingers. And the reason that I had asked about it was more along the lines of like, could it potentially help with like using it rather than for pain? Could it potentially help with like body imagery? Like things
That's
like that.
Question. Yeah, so we haven't used it specifically for body imagery, but it would be something that would be worth exploring. Yeah. A lot of the patients we've seen that was more body imagery for their uppers, at least, have done really well just with silicone prosthetics with passive devices. That's really helped that piece because I know they're incredibly lifelike. But if it's something that your daughter was struggling with, it would certainly be something we could explore. It's a great thought. Another question in the Q&A is, what are the simple non-surgical methods to deal with residual limb pain other than VR and TBR? You want to talk on that a little?
Yeah, I mean, definitely the medical treatments that we mentioned. Obviously we try to avoid narcotics and then step up to things like EpiPen, Lyrica, sometimes the SSRIs get used as well medically. And then therapists will do things like desensitization, mirror therapy, graded motor imagery. Those are things that can be done. And then sometimes the prosthetist is able to, put some extra padding here or there, offload a certain area if the person has a tender spot. that can preclude effective prosthetic wear. So there's a lot of different strategies, and we probably just try to get everybody's input on what the best things may be able to be done for it, instead of just jumping, to a surgical management. We try to see if we can exhausted everything else before we do that.
Yeah, and I think piggybacking on that, for residual limb pain, the first thing obviously we got to figure out is what's the cause of the residual limb pain. Is it a neuroma? If so, our neuroma strategy is one thing, and that's the desensitization, sometimes gabapentin lyrica, sometimes a cortisone injection. And then is it a residual bony prominence that's causing a irregular fit? If so, that tends to be working with the prosthetist to do it. Is it that they're having a lot of residual limb pain because as patients' depression gets worse, they experience more pain, in which case we're introducing the psychologist more so? Probably a combination of multiple things, beginning with targeting the root cause of that residual limb pain. All right, let's flip back to the chat.
Anaplastic resonance yeah.
Yeah, so the question is, would it be okay for residents to attend the training camp? And yes, we have had residents come visit us as well. We typically try to look at the schedule and pair it up when there's not already a group of surgeons coming, just so that everyone can get more individualized treatments. We don't have pre-matched residents come, just because we don't want it to give off like a favoritism that they already came and visited time with us before they applied for their match. But once people have matched into a hand fellowship, we'll allow them to come at that point. And certainly we've had, in fact, just last week, we had a fellow from HSS come spend time with us to see the clinic. So fellows for sure, residents that are matched, we have had as well. See if there's another QA. I think that's what I see. At this point too, it looks like people can unmute. So if anyone wants to type in the chat or unmute and ask more, we can hang out longer. If everyone's gotten what they wanted out of it, that's understandable as well. All right, Nicole, I think that's all I see in the chat.
All right. Thank you both so much. This was phenomenal. I wanted to just take an extra 2 minutes here, and I'd love to share a video that ÖSSUR and OrthoCarolina created, which showcases the OrthoCarolina Clinic and the multidisciplinary approach that they provide to the amputees, as well as share one of the first iDigits Quantum Foresight patients that were fit by OrthoCarolina and the prosthetic and occupational therapy group there. So I'm just going to share my screen here.
My name is Jackson Schrader. I'm from Casper, Wyoming. I'm 22 years old, and I'm currently a college student at the University of Wyoming in Laramie. I enlisted in the Army right after high school. I was 17, turning 18. I was home on leave, on holiday block leave, and had an accident at home, and that resulted in the amputation of 4 fingers on my left hand and a good portion of the top part of my hand. After the surgery, lots of follow-up care as far as coming back here to OrthoCarolina in Charlotte and seeing Dr. Loeffler and Dr. Gaston and just checking in on, how the surgical site is and how your function and comfort is. I would say having the individual digit control back is just breakthrough, life-changing stuff. I've used other prosthetics, mechanical and body-powered prosthetics, and those have their purposes and they have their function. And I use those for what I use them for, but this individual digit control has really given me a lot of the just basic function back that I didn't think I would have.
The Starfish surgical procedure was developed to create an interface between a patient and a prosthetic that would allow, for the first time ever, for a patient to be able to have individual digital movement and control of digits on a myoelectric prosthetic.
You know, for starfish in particular, the ideal candidate is somebody that's lost all of their fingers right about the level of the first knuckles. Because if patients have more than that, if they have length out to sort of the middle knuckles, then there's usually things we can apply to the remaining digits. And if it's too far proximal to like the level of their wrist, then they're really not a candidate. So it's really designed ideally for patients who have amputations of multiple digits around the level of what we call the MP joint.
We developed our clinic here at the Reconstructive Center for Lost Limbs as a multidisciplinary clinic to include not only the surgical and medical care, but having prosthetists available, having occupational therapists to help with getting a limb ready for a prosthesis, training a patient in a prosthesis once they have that prosthesis, addressing mental health issues, which are very common, following these types of traumas. So we have a psychologist on site with us as well who interacts with the patients.
The big advancements with the Foresight system, the new iDigits device, it still looks the same externally, but now you can have up to 4 different electrode sites, 4 different muscle sites to operate the device. So what you get with that is, first of all, you get individual finger movement, which you did not have with the older styles of devices. Also, what you get is a much more natural transition from things such as tip pinches back to close grasp. So you'll see people that can much more naturally be able to transition between grabbing a pickle jar and opening it and then quickly switching down to pick up maybe a sugar packet with a tip pinch, things like that.
All right. Thank you so much. I'll stop sharing here. But after sharing that video, is there anyone on the call here that has any further questions for Dr. Gaston or Dr. Loeffler?
There was one other question from the Q&A section. What are the simple non-surgical methods to deal with residual limb pain except the VR and TBR?
Yeah, we did. We jumped in and got that one. That was when we got it midway through earlier. That was more identifying that cause of the residual limb pain, neuroma versus bony overgrowth versus psychological influenced, and tailoring our approach to that. Those are all great. Thanks.
Okay, thanks again. Enjoyed all the questions and hope that was helpful.
Thanks for
Yes.
the time.
Thank you all. Have a great afternoon.
You
All right,
too.
bye,
Take
Nicole.
care.
Thank you.
Thank you.